Jason Crellin. I'm one of 2 pediatric emergency medicine physicians over at Danville at Geisinger Medical Center. They asked me to come by and to say hi. Before starting, I want to thank you guys for everything that you do. I have a lot of experience and background with EMS, and like we were saying, it's like you learn how to do it in the dark with your eyes closed upside down and backwards with about half the equipment that you need in some of the worst places in the world. And you guys do awesome at it. And thank you guys very much for everything. So I hope this is something that's valuable for you. It's kind of based off of some things that I put together for some of the flight medics when they come through and train with us. And it's kind of like, and I hope it's not too simple for anybody. I hope that you'll find something that's kind of fits your need wherever you might be. So, just as a side, I'm not like a super formal person. So if you have questions, just ask. Right? Don't be bashful. I'm only mean on the weekends or something like that. But anyway, so, and I'll have to get used to this thing being backwards. All right, so we have some objectives. We're going to talk about some basics of pediatric emergency medicine and the emergency management of children, focusing on, as always, the ABCs. We're going to look at the airway, breathing, circulation, and the Ds. I didn't include disability, but we're going to briefly mention disability and neurologic exam, as well as dextrose management in kids, which I consider like the other D. So, and it's a critical one. So if I go the wrong way, forgive me. Again, kind of backwards. All right. So you get a phone call, you get dispatched to the scene of a rural home where there's a 13-month-old male with a past medical history of a metabolic disease, not otherwise specified. Parents say that he's had fever, he hasn't been eating and drinking very well, he's been really sleepy, they've been really having a hard time waking him up. And when you arrive, you find a child that's listless with poor tone, you kind of go to pick him up, and that's about what you get. And he's got just a really, really, really weak cry. So when you get this phone call and you arrive on the scene, this is like a good day, right? Not the greatest day. And there's actually a lot of these kids that are tucked around in these communities. Some of them that live nearby, and some of them that live a long ways away. And you kind of never know when you'll get called to take care of one of these kids. So anyway, so I'm going backwards again. So what are the next steps? Yeah.
I mean, it sounds like the baby has somewhat of a patent airway, but I'd like to just make sure like there's nothing occluding its airway.
Yeah. So assess the airway. And what else? Vital signs. Vital signs are vital, absolutely. So get a set of vitals. Assess heart rate, right? Respiratory rate, temperature, blood pressure, right? All of those things. Kind of the basics. And I found that a lot of times when taking care of kids, it's not all that different than taking care of adults. Like the basics are the basics, but sometimes it's like an extra layer of stress when you have this little baby that you pick up and they're just kind of like this.
They can't communicate. They can't tell you anything hurts.
Absolutely.
Or what's bothering them. So that's what makes it a little scary.
Yeah, absolutely. And it's hard to know sometimes like what's normal and what's not. And so anyway, hopefully after this we'll be a little bit more comfortable with all of that. So the basics, starting out with the very basics, the simplest things sometimes end up being the hardest ones, but the most critical ones. And whenever I approach a pediatric patient, the first thing that I'm always thinking of is how much do they weigh? And that's kind of right up there with everything, you know, getting your vitals and everything else, because if you don't know how much they weigh, you really can't do very much. You can't really do much for meds. You're kind of stuck equipment size, all of that stuff. It all hinges on how big the kid is, right? As far as determining how big they weigh goes, there's not a whole heck of a lot of like crazy accurate science behind it. You can use the Broslow tape that will give you a ballpark estimate that's kind of a good enough estimate.
Wouldn't you expect the mother would know the baby's weight?
Not when they're freaking out.
Not necessarily, actually. I usually don't rely on the mother's estimate. I'll usually get my own estimate. And the reason is sometimes the kid grows and they're like, oh, the last time they were seen in the office, they weighed, 20 pounds, and now they weigh 30 pounds, and that'll change their drug dosing quite a bit. But also a lot of the times too, parents know the weights in pounds, and I mean, I'm not the biggest fan of doing math on the spot, and so just having to calculate the weight too, it's like, well, so it's 40 pounds, 40 divided by 2.2 is like maybe 18 kilos, and it's just sometimes it's just easier to lay the kid down and put them next to the Broslo tape, or say, you know, the child, the handy does it based on age. You know, a 1-year-old being 10 kilos, a 3-year-old being 15, a 5-year-old being 27. So 1, 3, 5, 7, 9 years of age being 10, 15, 20, 25, and 30 kilos. There's the Broslo tape, and I don't know if anybody actually has a scale in their rig. I've never seen one, but maybe on like NICU rigs that they're really worried about that. But for the most part, they're coming from a facility that will tell you what the weight is. But you need to know what the weight is in order to get going. So that's right up there at the top of the list. Then the next thing, so you mentioned vital signs, standard full set of vital signs, right? Respiratory rate, heart rate, blood pressure is important to get in kids, especially if they're really sick. Temperature, I think I might have said. But vital signs are vital. And the really tricky thing about vital signs in kids is that they vary with age. Do you guys have any kind of standardized tools that you use to compare vital signs by age on your ambulances, on your rigs? Yeah.
There's a chart.
Yeah, a chart,
There's
exactly.
a chart that you look at, but the chart is in the ambulance. It's not in the house when you go in.
Yeah.
So, you know, you go in there and you're getting your vitals and you're like, is that good or is that not good?
Yeah.
We have PD bills too.
Yeah.
Wheels, we
Okay.
have Braslos, because that's what the state requires. And now the Geisinger Go app, we might as well push that out there, has all those fun things on it.
Yeah. Is that the PICU app? It's a different one.
There's an EMS one,
Okay.
Geisinger Go.
Okay.
There's the Janet Weiss one.
Yeah, which is the one that the PICU developed.
Right. So there's
Okay.
apps for your phone, and everybody always has their phone with them.
Yeah, that's a very good point. And that's actually a really easy way to do it. And I have a friend that designed one too, and so there's any number of them, and most of them are free,
That's the good.
which is a great part. And then you always have them with you, but you have to know what normal is when you actually get the vitals so that you can compare. And you have to realize that as kids get older, their heart rates slow down, and their blood pressures tend to go up, and their respiratory rates tend to go down, and obviously their weights tend to go up as well. But I usually keep these kinds of tables around just for reference as well. Vital signs are definitely vital, and you can't ignore abnormal vital signs. And vital signs in kids are tricky too, because they can be off because of pathologic processes, like if they're really sick or in respiratory distress, or or hemorrhaging or something like that. But they can also be off if the kid's just really upset, right? If you have a 2-year-old that has a fever and you walk in and you check a finger stick sugar and they don't like the poke on the finger, they're going to scream and their heart rate's going to shoot up to 200, right, as they go climbing up mom to go running away from you, right? And so you kind of have to take things in context without sweeping them under the rug at the same time. So anyway, but it's important to have some frame of reference so that you can know about where you're at, and then you can kind of get an idea of how sick the kid is.
Can I ask a question?
Yeah.
How well do the auto cuffs work on small children?
They work pretty well, with some exceptions. So I mean, a lot of younger kids. So we generally don't get blood pressures in the emergency department for routine visits for kids under 4, simply because the second you inflate, like if a kid stubs his toe or sprains his ankle or something, we won't get a blood pressure on those kids. If we have a kid that I'm worried that's floridly septic and is really sick, then we'll get a blood pressure. But a lot of times if you inflate it, they'll get really angry and like scream and flail, and that that alters the blood pressure reading that you get. And sometimes that's all the better that you can do, but you just have to you can't sweep abnormals under the rug, but at the same time you can kind of take into account as part of the greater picture. And actually the blood pressure itself is one of the least reliable vital signs that you can see in kids, because it's one of the very last ones to become abnormal. So an abnormally low blood pressure is a pre-terminal event in a pediatric patient, Whereas in an adult, it's actually really common. Oh yeah, they're in septic shock. They have a fever and their blood pressure's 80/40, right? Kids, by the time their blood pressure starts to drop, you're already well behind the 8 ball. So anyway, but the blood pressures are really tricky, and more often than not, in those circumstances where you put the cuff on and it inflates and the kid's screaming, you'll get a really high number, and I don't know what to do with those beyond repeat it later. So document it, note it, and repeat it later. But usually we don't check in kids under 4 unless they're really sick for that reason. Otherwise they get a blood pressure of 150/120, and I don't know what to do with that. When the kid's screaming and yelling at me and kicking me because this thing's like squeezing his arm, right? Any other questions?
When you're doing a manual blood pressure, you put the stethoscope in the same place
Yep.
as for an adult.
Yep, same. And it works pretty well. You can do it both with the automatic cuffs and with the manual cuffs. Any other questions? Okay, move on to airway. Do you guys have a lot of experience with pediatric airways, with intubating kids and things like that? How about adults? Fair amount of experience intubating adults. So we all know from experience that there are certain airways that when we walk up to, it's like, all right, I got this. And then there are other ones that you go, oh crap, this could be a really bad day, right? And I found that little kids, you really have to, they tend to be pretty easy airways, but you have to treat them with a certain amount of respect, otherwise you'll end up getting burned. So I oftentimes approach mentally a pediatric airway the same as I would approach the airway in this guy, as one that I'm going to be prepared and I'm going to have backups and I'm going to be all ready to go with my first line choice, my second line choice, and my other backups, and I'm not happy in him until his airway is secured, right? And it's kind of the same with the little kid, that I'm not happy until their airway is secured. And there are also some anatomic similarities in that we'll talk about here in a little bit that make little kid airways fairly comparable to those of a morbidly obese adult with sleep apnea. So some of the major differences between the adult and the pediatric airway is obviously they're smaller and shorter, right? And the small size causes some issues with airway resistance. Have any of you, let's say we were to have, we'll do a thought experiment, right? If we were to go and run up the hill right there and back down, and then if I were to give you 2 hoses to breathe through, if I were to give you 1 garden hose and 1 straw, which one would be easier to breathe through? The garden hose, right? Because it has a larger radius and you can move more air through it. The pediatric airway is a lot smaller and you can't move as much air through it, obviously, right? Also, the airways are really short, and where that ends up causing you issues more than anything is if you do have to intubate a young child and intubating too far and right main stemming them, which is really easy to do, or the corollary is you put the tube in and everything's where it needs to be, and sometimes the endotracheal tube is only a couple of centimeters below their cords, and even just turning their head from side to side when you go to move them can actually extubate them, because it can pull the tube, it can retract the tube out about that far, right? Does that make sense? And so you really have to be careful when you're putting the tube in to make sure that you're not going too far, because it's not very small. But also, when you're moving them, you really want to secure the tube and secure the head. It happens all the time that kids get extubated after getting intubated. And it really doesn't take, literally just turning their head to the side can extubate them. So that's something to be very wary about. In general, kids have enormous tongues relative to the size of their mouth. And this young man models that perfectly for us. And that extra redundant soft tissue is not too dissimilar from what you would see in a morbidly obese adult that has a lot of soft tissue in the back of their airway, right? It gives you more stuff to maneuver around when you're looking. and it also makes them more likely to occlude their airway if they're not positioned well when you're bagging them, right? When it comes to putting in endotracheal tubes, there are some anatomic differences with regards to the epiglottis. So in the adult, the epiglottis is pretty broad, pretty stiff, right? And so when you insert your blade and you look and you can see the epiglottis, you're like, yes. And then you slide it right into the vallecula and you go to lift and that epiglottis just comes right up. And ideally you can see something in the back. I mean, you might just see arytenoids, but still. The pediatric epiglottis is actually quite a bit different anatomically. It hasn't quite developed to where the adults is. And there's actually two different types of epiglottises that you can get with kids. The first is in really small babies, like this little guy in the corner on that side. So he's like a newborn, right? And their epiglottises are like really small and really stumpy. And technique-wise, we tend to use Miller blades with little babies, right? And I found that their epiglottis is so short and so stumpy that if I go and try to grab their epiglottis with the Miller like you typically would, I can't grab the stupid thing because it's like so stumpy and so rigid that I go to grab it and it keeps like just popping right off of the tip of the blade. And so I actually end up having to use the Miller like a Mac and go into the vallecula to lift. And then life is grand. But that's kind of one of those things with really little babies, like kids that are this kid's size, that you have to pay attention to. By the time they get to be his age and older, their vallecula gets large and it gets really floppy. And that's in particular where the Miller blade is the best, because when you go to reach, you'll actually have to grab the whole epiglottis and lift in order to be able to see the vocal cords. But so, and then as they advance, that gets stiffer until it becomes what you normally see with the adult airway. So I found that causes the most problems in kids this age, is that people are like, I can't grab the epiglottis. And it's like, well, stop trying to.
So do you find, like, when a child starts to talk, like, does that epiglottis then, like, does that become more formed when they're talking?
It tends to be more towards school age, that it gets to be a bit more solid, like maybe about 6 to 9 years of age.
Okay.
And then it starts to become more and more normal. And so when they get to be up to about that size too, then you start. Then some of the kids are about as big as me at 9 years of age, right? No comment. But and some of them are a lot bigger actually too, which is saying something about me being short and something about them being big. But and a lot of it again has to do with just how big they are. Yeah, it usually tends to be in older kids. Another difference is that their airways, like most things with kids, they're really flexible, and their airways, the cartilaginous structures in the airway aren't very well developed, and so they can actually develop this Starling resistor-like effect, which is because, so in our airways, the cartilage rings are really solid, and so they're like a nice straw, like a nice plastic straw that you suck on that like doesn't collapse. The pediatric airway tends to be more like a wet paper straw that it's saturated, and when you go to suck on it, it can actually collapse a little bit. And so that's actually why kids have retractions and stridor and things like that a lot more easily than adults do, because their airways actually collapse when they breathe in really strong. Does that make sense? All right. Kids tend to have a really prominent occiput, and this is something that's pretty well known. It's very helpful to place some kind of towel wrap or something under the shoulders to better align the orotracheal angles so that they're not like rough. Just like we would never try to bag an adult like this, you don't want to try to bag a kid like this, but their big head puts them in that position at baseline. So paying attention to that, putting a towel wrap underneath really helps. And then lastly, well, next to lastly, the ever dreaded laryngospasm. Have any of you guys ever had to deal with this in a kid? It's not very fun. They have very sensitive vocal cords, and if you do vigorous suctioning, or sometimes even if they get reflux or a foreign body or something like that, their vocal cords can actually slam shut, and then they don't like to open again. And you can kind of bag them through that, but it's just something to be careful of and pay attention to when you're suctioning them. You want to make sure you get the crud out, but you don't want to go so deep that you're irritating their vocal cords. Other things, the narrowest part of the pediatric airway is not at the vocal cords, which is the narrowest part in adults, right? Which is why we can phonate so well. But the narrowest part is just beneath the vocal cords in kids. And that's why historically uncuffed endotracheal tubes have been preferred for children, because that space just beneath the cords is a bit narrowed and makes kind of like a cuff, essentially. And lastly, kids are really sensitive to medications that we give them, and well, it's either one way or the other. It's never like just down the middle of the road. They're either really susceptible and really sensitive to sedating medications, like benzodiazepines that you would give for a seizing child or something like that, or induction agents or anything else. But they're either really sensitive to it, or they soak it up like a sponge and kind of laugh it off. But kids, especially to have neurologic abnormalities or other congenital abnormalities, or that are really premature, really young, are really susceptible and really sensitive to the meds. And so don't be surprised if you give a dose of benzodiazepine and they decide to stop breathing. And that's okay, you can bag them through it. And it's just one of those things you have to be cognizant of. All right, so once again, I try to approach the pediatric airway like that of a morbidly obese adult with sleep apnea that is going to be horrible until the airway is secured. All right. Do you guys know the formulas for endotracheal tube sizes? No? All right, we'll get there in just a second. So cuffed versus uncuffed endotracheal tubes. So historically, uncuffed tubes were preferred because they were worried about causing necrosis in the trachea for kids. But more recently, we've kind of switched to using cuffed tubes because you can actually ventilate at better pressures with cuffed tubes. With the exception of really small tubes. So like when you're down below like a 3.5, an uncuffed tube is better because the cuffed is just taking up extra space. And I want that space to get as big of a straw down there as I can to help them breathe. Yeah, when you have a kid with like a 2.5 cuffed tube, it's just too hard to move air through it. I would rather have a 3.5 uncuffed tube. All right, and then as far as choosing endotracheal tube sizes, there is a formula that you can use, and it's also on all of the Broslow tapes and everything else, and on the wheels and on the apps. It will tell you what all of those things are. But if you're ever in a pinch, the endotracheal tube size to use is it's an uncuffed tube. It's age plus 16 divided by 4, or if you do your like math order of operations, right? Age divided by 4 plus 4, and that's for an uncuffed tube. And then to use a cuffed tube, you go a half size lower. So that's kind of like a ballpark way to get it. And then this thing. So all right. Any questions about airway stuff? No? All right. So we're going to talk next about breathing. So breathing is something that's really awesome in kids. And they kind of wear how they're doing. Well, they wear how they're doing on their sleeve. And it's critical to do a good exam. And this is one of the things that as a first responder, it's a lot easier said than done, because in order to look and to see how a kid's breathing, you have to expose them. And there are challenges with exposing kids, especially if you're outside in December at a car, at an MVC on the scene, and it's like, negative 10 degrees outside. You want to like see the kid, but you can't just strip them down in the middle of the road because they'll get hypothermic, right? But you really have to take the time and do a thorough exam and look under the shirt to see signs of respiratory distress in kids. And the signs of respiratory distress in kids include tachypnea. Sorry, that's really small. Retractions, supraclavicular retractions. You can see retractions up here. Intercostal retractions and subcostal retractions. Head bobbing, so when they breathe, their heads are bobbing. Nasal flaring, so their noses, when they suck, their nostrils like start flaring. Grunting. Do you guys know why kids grunt? Yeah, they're generating PEEP, just like the same as if you have an adult COPD or that's in distress. They purse their lips and they to try to recruit alveoli and to try to breathe better. Kids aren't that cool. They can't do that yet, and so they grunt, and they do the same thing with their vocal cords. And sometimes it's really hard to tell when they're grunting, if they're grunting because of pain, because sometimes they'll grunt like if they have like a perforated appendix, right? And they're like, because it hurts for them to breathe, or to tell if they're grunting to try to generate PEEP, and that's something that you have to pay attention to. And you can usually figure it out by kind of putting the whole clinical picture together. But grunting is important. Other noises, obviously, stridor and wheezing, right? I have some videos here with sound, and these are from parents that they sent to me here. So let's see how this works out. I'll turn up my volume. Let's see if we can get it. This one isn't making very much noise. Oh, is it not playing on your screen? Nope. It's playing on mine.
That's because the projection screen acts as a second monitor. You have to drag it over.
Sorry.
There you go.
Okay.
Perfect.
Man, my legs asleep. So you can see in this picture that the baby has subcostal retractions right there, just beneath the lungs. And you can see the supraclavicular retractions right here, as well as the head bobbing up and down with every breath. And that's what respiratory distress looks like. This is probably a 6-week-old baby. Ah, my leg is asleep. That table did not do me good. All right. So this is the next video that I have, and this is probably a 3 to 6 month old. Start to hear at the end, you can start to hear the stridor, right? You can actually hear it more as like a more coarse stridor initially that becomes more pronounced.
Does that
towards
kid
the
have
end.
an airway? What's in the kid's mouth?
Pacifier.
Oh.
A pacifier.
It helps actually.
Sucking away. But you can tell that this kid actually had croup with the upper airway issues, and actually maybe had a little bit of laryngomalacia, some like underdeveloped upper airway that just really collapses when he gets sick. But you can see the retractions, the subcostal retractions, as well as the supraclavicular retractions up here, and the head bobbing as well, kind of with every breath. And these are things, like I said, that when you're on scene and it's December and you're at a car crash or something, like it's really hard to tell because they have 80 layers of clothes on, and you probably won't see it unless you take a quick look. So being conscientious of the fact that they'll get cold really quick and you want to keep them warm, you do need to do a quick exam and look. So that's number 2. And got this kiddo.
So take your pictures on cheese.
So he's not quite as sick, but you can tell that he has stridor, as well as you can see a little bit of subcostal retractions when he's breathing. And so the ideal treatment for him would be racemic epinephrine, right, and a dose of steroids for his croup. And he doesn't have any nasal flaring as well. It's kind of all stuff to look at. So, all right, moving on. This is another little baby. did we already did this one? Am I just going the wrong way?
Yeah.
Yeah. Here we go. Oh, I know what happened. I think I sat down on the thing. And I shot it the wrong way. So this kid's grunting too. Right? It's really hard to tell if he's fussing or he's grunting, but he's actually grunting. And he has expiratory wheezes, right, on exam as well. And you can see how long his exhalation phase is. The grunting sometimes is really hard to distinguish from the fussiness, but all of that points to somebody that has reactive airway disease and some kind of obstructive process and needs albuterol, and would probably do really well with this. Let's see if we can do the right one. All right, this is another asthmatic. You can hear the grunting with each breath, right? And you can see some retractions with him as well. And he's belly breathing. He's using his belly to augment his breathing. And you can see some retractions here. The video's not quite as good. It's a little dark under his neck. Anyway, so those are some different videos, and so some of those things are really subtle, and some of them aren't. But that's kind of, those are the things that you're looking for. Looking at the nostrils, looking here, looking between the ribs, looking underneath the ribs, watching their exhalation phase, listening really close to things that you can hear. If you can hear stridor, if you can hear wheezing, if you can hear grunting, and paying attention to some of those subtle things. And in little kids, it's really subtle, right? In little kids, it's really subtle. And as they get older, it becomes a lot less subtle. But paying attention to those things can actually make a big difference for the kiddos. So let's move on. Are we good there? Any questions about that stuff? No? All right. Stridor versus wheezing. This is something that I see all the time. That people are like, oh, he was wheezing, he was wheezing, he was wheezing, and then when I see them, I'm like, no, it's stridor. And because they can have inspiratory or expiratory stridor, and really the difference is where the noise is coming from. And if there's any question, I usually listen here and listen here, right? If the noise is here, then they need racemic epi. If it's here, then albuterol will work well. If it's up here, you can give them all the albuterol in the world, and it's not going to do anything for them. And actually, if it's here, racemic epi will probably help anyway.
So which is the stridor then?
Stridor is upper airway noise, and in kids, their airways are so small that noise gets transmitted very readily to the lungs. And so if they're squeaking here, you'll hear it here and here. And sometimes it's hard to tease out if the noise is coming from here or if it's coming from the lungs. So in a process like asthma, it would be coming from the lungs, and in a process like croup, it would be coming from, or laryngomalacia or something like that, it would be coming from the neck. So it's just kind of a little way to sort through that. So we're moving on from breathing then to circulation. All right. So to kind of circle back for shock, how are you doing for time? You doing okay? All right. There are some physiologic differences between adults and kids that make kids in shock present a lot differently than adults. And the first one we've kind of already touched on, hypotension, is something that doesn't really happen very often in kids. And when it does happen, you're approaching the point where the kid's going to arrest, basically. It's a pre-terminal event. Kids will compensate, and they will hold on until the bitter end, and so once the blood pressure goes, you're behind the 8 ball. Fortunately, there are a lot of things that you can see before that will tell you that you're trending in that direction before their blood pressure drops off, and we'll talk about that in a minute. So essentially vasomotor paralysis and overt hypotension is way more common in adults. And it actually makes finding shock in adults a lot easier than it is in kids. So other differences, kids have really limited cardiac reserve, so their ability for their heart to like put out more is really limited. Their heart can't like beat more. They can't move more volume like with each beat like ours can. If I were to go run up that hill there, my heart could relax more and squeeze more to move more blood, and kids just can't do that. Also, kids don't have the same ability to increase their heart rate as we do. So my resting heart rate is like 50. And if I go for a run, I can increase my heart rate to 150. And so I can move 3 times the amount of blood just by increasing my heart rate. But a kid with a resting heart rate of say a 1-month-old with a resting heart rate of 150 can't increase their heart rate by 3 times, right? A heart rate of 450 just wouldn't work. It's not compatible with life, right? And so they can't move more blood just by increasing their heart rate. So they actually have a very limited ability to increase what their heart puts out.
ESO even throws out the invalid error when you try to type that in.
Yeah.
Vital sign row.
450.
No, that work.
Yep. So, but I mean, they'll kind of top out around 200, 250, right? And even still, that's fast,
Oh, yeah.
right? And the heart doesn't quite move blood very well when it's beating that fast. And problems with oxygen consumption is more common than delivery, and septic shock is often associated with myocardial dysfunction versus vasodilatation in adults. So, shock, it has 2 distinct. Well, there's several different ways to describe it. There's these 2 distinct phenotypes that you can see, and one is compensated shock, where kids don't have hypotension, and then decompensated shock, where they do have hypotension. And again, decompensated shock is a rare thing, and it's pre-terminal. Kids will keep their blood pressure. They can squeeze their blood vessels and keep their blood pressure up there until they're about to die. But so those are the 2 types. And when a kid is in compensated shock, then there are several things that we can see that can tell us that they're actually in shock, even though their blood pressure is normal. This table comes straight from PALS, and it looks at signs of shock in kids before their blood pressure goes. Tachycardia is a big sign of myocardial dysfunction and of shock in kids, especially tachycardia out of proportion, right? So like if you have a non-febrile, non-fussy kid with a heart rate of 210, then that's a problem, right? If it's the kid that you just poked in the finger and their heart rate was 150 and now it's like 210 and they're screaming and climbing up their mom, it's a different story. But tachycardia out of proportion is a sign. Looking at their skin is really important, and this has to do a lot with exposure too. Looking for skin color, temperature, and if it's pale, mottled, or if it's diaphoretic and like sweaty, kind of similar to what you would see in an adult that's like having a big, the big STEMI, that they're like pale and diaphoretic. You see a lot of those same skin changes, but you don't see the blood pressure changes as well. You can also see delayed capillary refill, which capillary refill is usually less than 3 seconds in a kid. You just kind of push on their finger and watch and count. And if it takes longer than 3 seconds, then chances are they're a little bit behind. We doing okay for time? Pulses are important to feel in kids. Central pulses and peripheral pulses. If they have strong pulses everywhere, life is good. If they have weak peripheral pulses, that can be bad. And if they have weak central pulses, then that's really bad. Your central pulses are going to be more brachial and groin, right? You're not going to hopefully have a kid long enough. Oh, and pulse pressure is important too. When diastolic pressure is really low, that's a problem. You're not going to have a kid, as far as kidney goes, you're not going to have a kid on your rig long enough to like measure their urine output. And if you do, then you're having a really bad day. Right? And then obviously, if you're with them long enough to see if they're having intestinal malfunctioning because of hypotension and shock, then you've had them for way too long. And anyway, We don't want them that long, right? All right. So identifying shock is tricky in kids. It really is, and it requires a lot of practice and a lot of attention to some of those subtle signs, like pulses, capillary refill, what their skin looks like, as well as mentation, mental status. One of the first things in kids that goes when they're not perfusing well is when they're not perfusing their brain well, is they become a little bit listless and a little bit more sleepy than normal, kind of like the kid in the vignette at the beginning. So fluid resuscitation. Having identified a kid that's in shock, it's time to do something about it, because that's what we do. We're doers, we fix things, we save the day. As far as fluid goes, normal saline is the preferred resuscitation fluid, and I'm assuming that's what you guys have on all your rigs. Standard fluid bolus volume is 20 milliliters per kilo. So if you're going to give a kid fluids, you want to give them 20 milliliters per kilo. And that's why that weight is so important. And 20 milliliters per kilo is the magic number, with one exception, and that is if, with one exception, and that is you want to give 10 milliliters per kilo if it's a kid with like a bad heart or bad kidneys. Kind of the same as you would with an adult, right? If you have an adult that's on dialysis, you're not going to say, hey, let's like hang 2 liters, right? Because you're probably going to make it worse, right? Or if you have somebody that's having the big STEMI, you're not going to be like, hey, let's just bomb them with 2 liters, go for it, right? You'll probably start slow, and you can always give more. It's really hard to take it back. But so for those kind of more fragile kids, you give 10 milliliters per kilo. So 10 milliliters per kilo of cardiac disease, renal disease, or if you're unsure about those two, if they may have it, then give 10 and then give 10 more. And then as a convention, we assume that newborns, like kids less than 30 days to 60 days, we presume that we don't know if they have a heart disease or kidney disease or something like that, and we'll just give them 10 milliliters per kilo as a fluid bolus. So, does that make sense? So your volumes are 20 milliliters per kilo unless cardiac disease, renal disease, or newborn, or if you don't know about any of those. All right. Maintenance fluids are really critical, and they should always contain dextrose. I'm guessing that you guys don't have D10 half normal on your rigs. You probably have D10, which you can run for a little while, and that's fine. Dextrose is important, especially for infants. You want to make sure that they have enough dextrose. So kids are a lot different than us when it comes to sugar. I got plenty of stored right here, right? I could go for a couple of days and be fine. And kids, actually, their livers don't store glycogen. They don't have the ability to store it, and they burn through it like crazy. And so they get hypoglycemic really quick. And so you want to make sure that the maintenance fluids have dextrose. So D10 half normal, or D10 for young infants, and D5 half normal for other children. You guys have D5 half normal, I imagine, on the rigs? No?
We have normal.
Just normal
And
saline?
D10.
Okay.
Normal saline, D10, and D5W.
What's the half?
That's why we have
Half normal saline. So that means that it has half the amount of sodium chloride that the regular normal saline has. But that would be something perhaps that you would get if you picked up a kit from another facility, that they would say, hey, can you run this? And so if they don't, then you might want to say, hey, should we be giving the kids some sugar on the way there, and remind the doc, and they'll probably say, yeah, I probably should have done that.
Think of it as a lemonade tea core.
Yeah.
Half lemonade, half iced tea. Yep.
Yeah.
Half D10, half normal saline.
They need the electrolytes, and they need the sugar.
And the sugar, yep.
Yeah.
Question, what's the normal blood sugar for a baby?
All right, we're gonna get
And
there.
when will out?
We're gonna get there. That number varies a little bit. And then for traumatic brain injury is kind of the one exception, and you want to do just regular normal saline for anybody with traumatic brain injury, because if you give hypotonic fluids, it'll cause swelling in the brain. So, first do no harm, right? As far as maintenance fluid rate goes, so sometimes it's like the easiest things that end up being the hardest things, and this looks like a lot of math, but this is actually a pretty simple principle. It's called the 4-2-1 rule, and are you guys familiar with this at all? So this tells you how fast to run fluids for infants. And I don't even know if you have pumps on board that can tell you how fast to do it. Do you?
We do carry pumps in our trucks.
Okay. All right. Fair enough. So to determine maintenance fluid infusion rate, it's the 4-2-1 rule, and so you use 4 milliliters per kilo per hour for the first 10 kilos, 2 milliliters per kilo per hour for the next 10 kilos, so that gets you up to 20 kilos of body weight for the kid, and then 1 milliliter per kilo per hour for every kilo thereafter. So we'll start with some examples. If you have an 8 kilo infant, right, then you're going to run your fluids at 4 mils per kilo per hour for each of those 8 kilos. So that's going to be 4 times 8, which is 32 milliliters per hour, right? Oh, there we go. So that's 32 milliliters per hour. Does that make sense? So it's 4 milliliters per kilo for the first 10 kilos. Since we haven't hit the first 10 kilos yet, it's 4 times 8. For a 14 kilo infant, you have 14 is 10 kilos plus 4 kilos, right? And so you're going to go 4 mils per kilo per hour for the first 10 kilos. So that's 40 milliliters per hour. And then you are going to do 2 milliliters per kilo per hour times the next 4, which is 8. So it's going to be 48 milliliters per hour, right? And then if you have a 22 kilo infant, you're going to do 40 milliliters per hour for the first 10 kilos, right? And then you're going to do 20 for the next 10, right? 2 times 10. And then you have 2 more left over, and so it's going to be 62. Does that make sense? And there's actually a lot of complex math that is based on, and I don't like complex math, and this is actually like borderlining on too complex for me. So anyway, but that's how you know how much IV fluids to give a kid at maintenance.
So like, let's say, your baby's febrile and it's vomiting.
Yes.
So is there like a formula to increase that?
Yes. But
Or not for us?
we're not going to do that.
Okay.
Because even in the hospital, they don't, honestly. And to be fair, so if you have a kid that you need to acutely resuscitate, you give them a bolus, right? And we talked about bolus volumes already. And you can bolus them a few times, and that's fine. But if you're going to give fluids beyond that, and there's still some losses, so this is just to maintain even, right? Healthy kid, not eating and drinking, maintaining even. You can do 1.5 or twice maintenance for those kids, and that's a thing, and that's perfectly fine. And so if it's you're giving 60 milliliters an hour and the kid's still been vomiting and stuff, you can say, well, 60 is what it should be, but he's still vomiting, so I'm going to do 1.5 times that, which is 90, and just leave it there, and that's fine. And then if you want to get really fancy, then you can watch like the urine output. You can like titrate to get so many, but it's not worth it. Not worth it. And you're not going to have them that long. All right. So which IV fluids do you use? For maintenance fluids, for infants, we talked about this. D10 half normal for infants, or just D10. All other kids, you can use D5 half normal. Be careful again with hypotonic fluids in traumatic brain injury. So, are we doing okay? Let's see, how are we doing for time? 7:20? We're good? All right. We'll come back to this. How's that? We'll come back to this. We'll skip a little bit, and then we can come back to congenital cardiac stuff if you want to, depending on how we're doing for time afterwards. So, to talk about it really quickly, disability in ATLS refers to kind of your neurologic exam, right? Which is pretty simple in the ATLS world, right? Pupils, GCS, can they move everything? Can they feel everything? Maybe a rectal exam if you're nice. But in kids, neuro exams are really hard to do, right? Because there's different developmental stages, there's different things that a newborn can do, that an older kid can do, and the neurologic exam obviously gets easier and more approximates the adult neurologic exam the older the kid gets. Because you can say, hey, how old are you? And you can say, I'm 7. And you can say, where do you go to school? Oh, I go to Liberty Valley. Yeah, what do you like? And you know that their GCS is 15, you know that their brain's functioning okay, and you can say, give me thumbs up, and they'll give you thumbs up. Wiggle your toes, and they'll do it. And stick out your tongue, and they'll say no. Right? No, my mom told me not to do that. In fact, she told me not to talk to strangers, so we're done here. But obviously, the younger you get, it's really hard to get a good neurologic exam on kids. And so you really have to, kind of similar to the breathing and the circulatory things, you have to pay really close attention to the child to be able to see abnormalities. In the scenario, the vignette that we started with at the beginning, the kid had really poor tone, right? You picked him up and the kid just kind of drummed. And that is obviously neurologically not normal, right? Normally kids are like, and they're kind of like little hulks, right? They pull on their arms and they retract and they're like, anyway. But so tone abnormalities, hyper or hypotonia or seizures, right, is abnormal. So too much motor, too little motor, and you kind of have to get an idea of what's normal, what's not. If you don't know, the parents are your greatest resource. Like, what is this kid normally like? Is a great question, and it's one that I ask parents all the time. What is your child normally like? Especially when you get to the kids that have the complex history. Because mom and dad will often say, well, you know, he just kind of lays in the chair and we feed him through the tube in his stomach and he breathes and pees and poops. And if that's what's normal, if that's where you are, then you're probably okay, right? But if you ask mom and she's like, man, he's normally like climbing up the walls and stuff and you're really having a hard time waking him up, then you've got a problem, right? So the parents are actually your best friends when it comes to this because you can say straight up, what is your kid normally like? And they'll tell you. And parents have a tendency to exaggerate sometimes. Take whatever they say at face value. You'll never be wrong if you go with what they tell you. Interactiveness. So by your exam, you can see their tone, what they're doing. Interactiveness is something that varies a lot with age. Kids get more interactive the older they get. Just to differentiate a little bit too, there's like kind of two words that there's one word that's like that hits my ears and like makes me shudder a little bit, and that's lethargy. To me, that's like the L bomb or like the F bomb, right? It is, and that's not to say that it shouldn't be ever used, but it means that it needs to be used appropriately. So lethargy implies that a kid is indifferent to what's going on to them. So a lethargic kid is the kid that, you know, the 18-month-old that should hate your guts, that you poke their finger to check a blood sugar, and they kind of like go, you know what I mean? Versus a kid that's just kind of sleepy, and then once they wake up, then they hate your guts and they're screaming all over the place. There's a big difference, and the difference is apathy. When they no longer care about what you're doing to them, then they've become lethargic. Otherwise, they're listless. Just kind of one of my things. Other neurologic things are consolability, so I mean, normally kids are very easily consoled, especially by their family members, right? And so, with some exceptions, if there's like this huge rush of people and things, they might be scared, and that's fine. But generally, they tend to be consolable. Look and gaze. We'll talk about all this stuff in a minute, but you can learn a lot by the look. So tone, hypotonia, we talked about. This is the gaze. Sometimes you get the kid that just has that like 10,000 mile stare, and they're just, you know, a kid this age that should be paying attention to you. If you walk up to a child that's this age, maybe like 3 or 4 or 5, and you say, hey, what's up? Or you pinch her or something like that. If you pinch her, she'll probably hate your guts forever. But if you talk to her, right, she should do something back. But if you're just getting the 10,000 mile stare neurologically, something is not right. And speech is also something important to consider, and cry. And again, the parents are your best friends for like, what is your kid normally like? Because if they're normally like talking up a storm and now they're just kind of like, and not really saying anything, then neurologically there's a problem. These are a couple other videos that I had. So this is a 6-week-old actually was having seizures, and this is pretty subtle. So and this one was really sinister. And when I saw this kid first, I was like, so the parents brought him in, and the chief complaint was actually respiratory distress. And I was kind of like, you know, the SATs were fine, and I didn't see any secondary signs. He was tachypnic, but I didn't see any like retractions or grunting or nasal flaring or anything like that. And while I was like watching the kid, he like I noticed that every once in a while his eyes would kind of deviate to the left and would kind of like stay over there. And when he was doing that, he would just kind of like move his arms over to the left. And they were really subtle movements, and I was like, I think he's having seizures, and he ended up having seizures. But what really clued me off to it was that I asked Mom, I was like, so what is he normally like? And she's like, oh, normally he's like babbling and like, you know, moving all around, and she's like happy as a clam, but he's been doing this every once in a while, and she's like, that's actually why we brought him in. I was like, I don't think he's in respiratory distress. I think he's upset because he's seizing. So this is a video. Yeah. It's really hard to see his eyes.
You okay, Ari?
But so you can see right here, like his eyes kind of started to get forced over to the left. You can kind of see the light of the eyes and looking this way. But you can see the whole time that his arms are kind of like stuck over here on this side. And then it started that I'd like move them over here, and then he would like bring them right back over there. So, I mean, sometimes it's really subtle. So you can kind of see how he's like,
You okay, Ari?
almost like bicycling over there on that side. So, and this was another kid that I saw not too long ago that was having seizures at home. And so this child obviously has Down syndrome, right? But these were this was one of the spells. Mom sent me the video. And so she brought the child in because the child was having these abnormal movements just over and over and over again. And so, again, tone is important, and paying attention to what the kid's doing is really important.
Bless your heart.
And so, the kid would have a bunch of those spells and then get really sleepy.
Now, I know in adults epilepsy, they don't really know exactly what causes it. In children, is it pretty much the same?
Sometimes. Sometimes they know what causes it, and sometimes they don't. And they do some looking into it to see if they can fix the cause. And if they can't, then we consider it idiopathic and we treat as if, you know, we don't know what the cause is necessarily. So, all right. So that's, is that one? Switching here. It's not switching. All right. I think I broke it.
Don't look at me, John. Get out of here. Thought we used to be friends.
Yes, it worked. All right. So, then to talk about the last D, dextrose. So, sugar is the kid's friend, right? They don't have the stores that we do. They burn through really quickly. And so, I mean, yeah, to go back to my memoirs of shame. I had a kid once that came in during fellowship for a simple febrile seizure, and we had to, I can't remember what kind of testing we had to do. I think we tested like a strep swab and whatever, or something like that. And we were waiting for it to come back. The kid was fine, and he had this like pink sippy cup that he was drinking from, and I thought he was drinking juice in it. And anyway, like an hour or two seizure, and we checked his sugar, and sugar was in the 30s. And I was like, what's in this stinking sippy cup? For heaven's sakes, he's been drinking all this time. They're like, oh, it's just water. It's like, water, why are we drinking water? And so he came in with a simple febrile seizure, and then he ended up having a hypoglycemic seizure. And I felt like the biggest jerk in the world, right? And so there are things, the sugar is something that you want to pay close attention to in kids, because it can cause a lot of issues. So as a truism, all sick kids should have a blood sugar checked. Period. End of story. If they're in respiratory distress, then they're burning sugar more than they should, and if they haven't been eating well, then they're probably not eating well either, because they're working to breathe and not to eat. Check a sugar.
Correct.
If they have altered mental status, check a sugar. If they're septic looking and febrile and like, look, gosh, awful, check a sugar, because they're burning more sugar and they need more sugar. Check early and check often. In worst case scenario, it's a finger stick, right? If the kid's running around your rig and you have to like restrain them down, then you could probably hold off on the sugar, right? But check early and check often. Now to get to the numbers like you asked about, for the numbers in the neonatal period, the immediate postpartum period, it's a blood sugar less than 40 is abnormal, and outside of that it's 60, just the same as you would treat in adults. And if you can do it treat it orally, then that's fine, but you may need to treat it intravenously. And in really young kids, you'd say, well, just give them a bottle, or breastfeed them, or give them, if they're older, have some juice. You guys probably have juice on your rigs too now. No? Okay. Glucose gel?
Yeah.
All right.
Tastes amazing.
It stays better. It keeps better. So, as far as intravenous sugar replacement goes, D10 is safe for all ages, and it is actually the preferred fluid for younger children because it causes less sclerosis of the veins than some of the more concentrated solutions. D25 can be used for like kind of school-age children through adolescence, and D50 they probably don't use. They're not. I heard they're getting away from here.
We only have D10. I think Berwick still has some D50 left. Everybody across the board is kind of
Just going to D10, and that's fine. You just have to give enough, and you're good. But D50 can be used for adults. You just run into issues with sclerosis of the veins and things like that. Anyway, and big bumps in blood sugar that can cause other problems. It's actually not that much sugar. It's less than the Snickers bar that they'd like to eat otherwise. So this is always the big question, though. So if you have a kid that's hypoglycemic, how much sugar do you give? And to remember that, there's this lovely rule of 50s. Has anybody heard of this? So 50 is the magic number. If you have D10, then you're going to give 5 milliliters per kilo, because 5 times 10 is 50. If you have D25, you're going to give 2 milliliters per kilo, because 2 times 25 is 50. And then if you have D50, well, guess what? You're going to give 1 milliliter per kilo, which is 1 times 50 is 50, right? And in most adults with D50, you would just give an amp, right? Which is 50 milliliters, right? So that's actually kind of giving. And you can give it over like 3 to 5 minutes is fine. You don't need to like run it in over hours, and you don't just want to go either. So. All right.
No.
And then to go to exposure, we've already talked about this. So this is what kids look like in the winter, right? And
Story.
And so, but the point being, so where I did fellowship too, I did it in Rochester, New York, and we had one day a kid that was dead, blue, pulseless, nothing. That was brought in like this on a cold winter's day that had nothing but like a pair of eyes sticking out from the hood. And by the time we got the kid undressed, we were like, oh boy, and started working on the kid. But if you don't undress them, you'll never know. If the person at triage didn't say, let's take the kid out of like the 18 layers, we would have never known. And the kid would have sat in the waiting room probably for 2 or 3 hours dead, right? Which never looks good. So, you're probably not going to have that experience, but if you don't undress them and actually look at them, you're gonna miss on some of the subtle things that you'll see with airway issues, with breathing, some of the subtle circulatory issues, as well as the neurologic issues. You're never gonna see this kid moving anything. She's like stuff like this, right? So, and again, you have to balance that. It's really hard to balance that on the rig and on the scene. And so, but you need to do the best you can to get a good exam and to protect the child at the same time. And for those of you that are more accustomed to this view, this is actually what a lot of the stuff is that we covered. It's just kind of an ABC's approach rather than the pediatric assessment triangle approach. But this is very valid, and this is actually a lot of the same stuff that we've covered. So, how are we for time? We're good? Are you guys doing okay? Do you have any questions on what we've covered? No?
I'd like to hear about the cardiac stuff.
Okay, that's what I was going to ask next, because that's a little bit, some of it's a little bit more complicated. I think it's worth seeing to like kind of understand. So when it comes to pediatric congenital cardiac disease, there are textbooks written that are like, yay big about all of the different diseases, and quite frankly, there's like, thousands of them, and it's pretty much impossible to know all of them, but I found that kind of learning just a couple of basics actually goes a long way. It's kind of like the give a man a fish, teach a man to fish type of thing, right? If you get just enough, you can kind of understand how to get by and how not to kill anybody at the same time. So, because sometimes paradoxically, doing things that you think would be really helpful for these kids can actually make it worse, which is something that we all don't want to do, right? Like we all just want to help people, like period, end of story. So, but kind of understanding how things work helps to prevent you from doing things that will hurt the kids. So, all right. So, I am a horrible artist, and this is like full disclosure, right? I am like the worst artist ever. And in fact, with how this is, can I just borrow that board? Is that cool?
Sure.
And we can draw on the board. Is that cool? This was my attempt to draw, and I had it set up so that I could draw on the screen, but.
Hold on. Suction cup's moved.
Oh, he's breaking it. He broke it.
No, I got the suction cup. We're good.
She broke it.
I did. Just tell them it was made. They're not gonna.
All right.
And for Vanna White.
You already did this evaluation, right?
It's done. I'm good for a year.
So,
Nurses are so good.
are all of these dry erase markers?
As
I'm
far
not
as I
gonna-
know.
Well, they
I'm not
could
going to
be.
ruin your board.
It might be.
If I do, it's his fault. So, as far as things go, this is kind of my rough drawing of a heart. And so, on the sides, you have the superior vena cava, right, and the inferior vena cava. So what this is the fetal heart. This is the heart when it's in the uterus, before a baby comes out to the real world. What? We're good? All right. And so my heart is, I guess, let's see. We can do a circle. That'll be fine. And it's got 4 chambers, right? And a couple of valves, right? And so this is the vena cava that come in here to the right atrium, right? And then you have down here the right ventricle. And then up here you have this big hole called the foramen ovale. And down here, out of the right ventricle, comes the pulmonary arteries, right? And then up here, of course, you have the left atrium, right? So your pulmonary veins come back into the left atrium. PV, come back into the left atrium. And then you have your left ventricle, your big, strong left ventricle. And then you have your aorta that comes lied yet, right? And connecting the pulmonary artery to the aorta is this thing called the Ductus Arteriosus, right? And then we have like our two lungs right here. They're really small because they haven't been inflated yet because baby hasn't breathed yet. They're squished. They are squished. So in the neonate, before being born, in the fetus, I guess, the blood comes back up through here and comes back into here, and I guess we'll back up a little bit. So the lungs, like I said, haven't inflated at all. The lungs are like squished up balls, and the pressure there is really high because they're not inflated and they're not open. And because the pressure here is really high, the flow is low, right? Just the same as it would be with any other fluid, right? Fluid doesn't flow uphill, right? Because the pressure gradient that exists. So the flow, which is Q, flow, is low. Which, I mean, to be fair, you don't need that much blood going through your lungs, right? Because they're not breathing. You don't need to oxygenate blood there. You just need to get enough blood there so that things can grow and develop and not die, and that's all that you need. But so, because the pressure here is really high, the pressure here is really high, right? And the pressure here is really high. And so if you have really high pressure here and lower pressure here, and you have a hole here, blood flows across the hole, right? Onto that side. Most of it does. A little bit of it goes down here, and then a little bit of it goes down here, and it gets to this other junction. And again, the pressure here is really high. The pressure over here isn't quite as high. And so a lot of the blood goes across the ductus arteriosus, and then you get like a little trickle into the lungs to keep them alive. And then that blood comes back into here, into the left atrium, and then it all goes out, down, through the left ventricle, and out the aorta, right? And so this is what things are like in the neonatal stage.
But it's got to get to, I mean, how is it getting oxygenated?
It is getting oxygenated by mom.
Right. Can you
So,
explain that?
so this is so it comes from here, so mom is over here. It comes back through the liver and everything. Mom puts the oxygen into the baby's blood. And so the baby doesn't need the lungs to do it when it's inside the uterus, right? So inside the uterus, the pressure here is really high on this side, and then the pressure here is low on the aortic side, and the left heart and the aorta, the pressure is relatively lower than the right side. And so, because the pressure is lower, the flow is higher, right? We're good? All right. So, when baby's born, baby comes out, baby screams, because that's what babies do. And when they do that, they inflate their lungs a lot. And when they inflate their lungs a lot, their lungs open up, and now they're not like a big ball of like pressure. Now they've opened up and they've expanded, and the pressure on this side actually goes down. And so when the pressure on this side goes down, what happens to the flow? Do you think more blood flows there or less blood flows there? More blood flows there, right? And so as the pressure here drops on this side of the heart, there was high pressure here and lower pressure there, and now it starts to creep down and the pressure here starts to be greater, and so the flow across here stops, right? And this actually closes off.
There's a little flap on it.
There is a little flap, and it's like a little pressure valve that once the pressure's flipped, the blood stops. The blood kind of starts to go back this way, and that snaps the door shut until it kind of scars over, and then it's done. And so you don't really have blood flowing through there anymore, the pressure here's gone down a lot, and so blood flows down into here. And then similarly, you're in a position where the pressure here's starting to drop a lot, and so there's a lot less of a pressure gradient driving blood across this,
Does
right?
that one also close off?
It does close off. It absolutely does close off. It closes off anatomically at like 24 hours, and then, well, kind of physiologically at about 24 hours, but then like definitively by about 2 to 3 weeks, it's done. It's actually, it becomes like a ligament after it totally closes up. But so then this closes up, and then all of the blood flows to the heart, or flows to the lungs, right? We like it when all of our blood flows to our lungs, and all of our blood flows to our body. So, and then the pressure after a while on the left side of the heart becomes dominant, right? Like the pressure on the left ends up being the greatest. So that's kind of how things work with birth, and that's what kind of showed here. All right, so, all right, let's give me a second. So, we kind of navigated some of that. And so this concept of flow and pressure is really important. And in fact, in cardiology, in pediatric cardiology, there's this number, or this ratio called the QP to QS, which is essentially how much blood flows to the lungs relative to how much blood flows to the rest of the body. And ideally, we want 100% of our blood to flow to our lungs and 100% of our blood to flow to our body, right? So we want that to be balanced, right? Because in most of us, these two systems are like, they're in series, right? Does that make sense? So, now, to talk about special kids. So this is the QP to QS. So you want there to be a good balance between the two. So, most of the kids that have cardiac issues have something that makes it so that blood can flow abnormally from one side to the other. Whether that something is something they were born with or something that we put in surgically, it's something that makes it so that blood has a way of bypassing the lungs. So that can sometimes kids, so very rarely, most kids this closes off, sometimes it doesn't. And that's called the patent ductus arteriosus. The most common thing that would cause this in any kid is something called a ventricular septal defect, or a VSD. That's actually the most common congenital cardiac disease. And so that puts a big hole here, and if you have a pressure difference on either side, then blood's gonna flow across that. If the pressure's the same on both sides, then it'll just go freely normally. But if the pressure is low here and the pressure is high here, which way is blood gonna flow? It's gonna flow from high pressure to low pressure, and it's gonna flow into the lungs, and it's gonna put too much blood into the lungs, right? Alternatively, if the pressure becomes low here, then blood is gonna bypass the lungs altogether. So when you have a kid that has an abnormal heart because of either a ventricular septal defect or a surgical shunt or a ductus arteriosus, you want to balance, you want to make sure that they are getting enough blood flow to their lungs and enough blood flow to the rest of their body. And that's like your only goal. So the first thing that you see in a lot of kids that have heart abnormalities is their SATs are like 70%, right? And you walk into the room and you see this kid that's like pink and has SATs of 70%, and you go, oh great, this could be a long day. That number is really important, and that's a number that all parents know. What should their oxygen SAT be? And that is important to know because oxygen is one of the things that affects this ratio. So, things that do affect it, so oxygen is a very potent pulmonary vasodilator, and so it actually increases blood flow to the lungs. So you can see that if you have a system where blood can flow from one side of the heart to the other, if you make too much blood flow to the lungs, you can actually make it so that you get CHF symptoms, right? If you have way too much blood flowing to the lungs, that you're like drowning your lungs in blood. Or alternatively, you can actually go into shock if you give so much oxygen that you open up your lungs so much that all of the blood flows to the lungs and none of it flows to the body. Does that make sense? And so that's why that number is so important, because if you have that kid whose oxygen stats have to be at 75%, that's where their baseline is. Say today they're 65%, right? It's okay to put oxygen on the kid with oxygen sats of 65% to get him up to his target. If you overshoot, then you can, so say you put them on a non-rebreather, right, and you bump their oxygen sats up to 100%, then that will create one of those scenarios where I was saying that you can actually make it so that the kid's blood almost stops going to the rest of their body.
But that can't persist, because otherwise it'll drown.
They'll die. Yes. Yeah. And so that's one of those things where giving them too much oxygen can actually be harmful. And that's why talking to the parent and saying, so where are their sats supposed to be, is such a good thing. Because she'll say, Jimmy's sats are supposed to be between 75 and 85%. And that's kind of your target. So you don't want them to be at 65, but you don't want them to be at 100. Because if they're at 65%, so giving oxygen opens up the blood vessels in the lungs, taking oxygen away closes up the blood vessels in the lungs. And that makes it so that the lungs get even less blood flow. And it makes it even worse. And so it takes the balance of blood flow to the lungs and blood flow to the body, and it shifts more blood away from the lungs. Does that make sense? So by taking oxygen away, it increases the pressure a lot. And it further worsens the perfusion to the lungs, which further worsens the oxygen sats, and then it's like this vicious cycle.
So in theory, say the child's mother does say it's supposed to be 75%, and you find that you're actually above it without applying oxygen. Is this a child that would be a candidate for something like a CPAP? Carefully, obviously, but.
I mean, typically,
if they're looking good, I'm not touching them.
If it's a work of breathing issue, perhaps, but something else that you can do is, so you, PEEP and FiO2 are two different things, right? The PEEP can influence the oxygen sats,
Yeah.
but it can also help with work of breathing.
Right.
But that's not a kid that I would put on CPAP and then put on an FiO2 at 1,
Okay.
right?
Right.
You don't want to give them 100% oxygen,
No,
because then
no.
that will just make
It would
worse.
be
Right.
worse, yeah.
But if it's a work of breathing issue, then that could potentially be helpful. But you'll just want to be, and you obviously
That's the, hey, could you just drive a lot faster?
Yeah,
for me?
you can't
Moment.
take the
I don't wanna
oxygen
take oxygen
sat
away. I'm just thinking,
right?
well, obviously if I would listen and they'd have wet lungs, that would be something I'd consider anyway, but I don't think we have PEEP. We don't have
You
CPAP,
probably have-
CPAP anyway, so we're
You
good.
probably have high flow.
Oh,
Yeah,
we're breaking.
Yeah.
the closest thing that we're going to give any food would be using a bag valve mask with assist
Let's
ventilation.
not and say we did, but
Without oxygen
But just
attached, because that way
conceptually,
Immediately, it's
though,
You'd be
this
bagging it
kind of
in
paints a
there.
picture where giving too much oxygen could be a bad thing,
Yeah.
right? And so it's kind of like the Goldilocks thing. You don't want to give too little, you don't want to give too much, you want to get it just right. So that just the right amount of blood is flowing to the heart and the lungs. And that right amount will be dictated by what mom says that the numbers should be, right? Moms are your best friend, man. They're like the smartest people in the room, like 110%. Opiates. So opiates are something else that tend to cause pulmonary vasodilation and relaxation and can actually shift blood to the lungs. Agitation causes pulmonary vasoconstriction and like this big sympathetic surge, and then actually can decrease blood flow to the lungs. Needed chest position like compacts their body and it makes systemic resistance higher, and so that can actually push blood across into the lungs. Does that make sense? And then there are some medicines that you can give. Do you guys carry phenylephrine?
Yeah, right.
No?
No.
Okay, all right.
No.
Fair enough, fair enough.
Would like to.
But yeah, neosynephrine or ephedrine or levofed. These are all systemic vasoconstrictors that actually, if you give them, they push blood across into the lungs. So there is one scenario. So to kind of contextualize it. So there's the most common cyanotic congenital cardiac disease is called tetralogy of Fallot. And this will kind of be it. And with tetralogy of Fallot, they have a couple of major issues with their heart. So they have a large VSD, so they have a huge hole right here in their heart. So they have a huge hole in their heart, and the aorta and the pulmonary artery are like really close together. And so the blood almost doesn't care which one it goes into. And just because they're so close together, right? Yeah, it's kind of like if you were to have a hose and you have like something to split it. And yeah, if you have one that's splitting off this way and one that goes straight, like it's going to go straight more readily, right? And shooting straight off at a right angle. But anyway, so they have this condition where they have a really thick right heart. And they have a lot of narrowing at the opening here. And so it's really tight and there's really high pressure. And they have this huge hole in their heart. And so they're actually set up, since this is so narrow and so tight, the pressure here tends to be pretty high, right? And so sometimes it's really hard to get blood flow through there. And so if there's a huge hole here, and you're a blood cell in the right ventricle, and the pressure here is really high, and the pressure here is quite a bit lower, you're gonna say, I'm gonna go this way, right? I'm gonna take the path of least resistance. And so what ends up happening is sometimes in kids with tetralogy of Fallot, they get these things called TED spells or hypercyanotic spells. Or what happens is they have a lot of reasons to have really high pressure in the lungs, and they get pissed off, or they wake up and things get thrown off for a little bit, and then all of a sudden they stop sending blood to their lungs altogether. And so when they stop sending blood to their lungs altogether, that blood doesn't get oxygenated. And so when you have when you have a very small amount of oxygen, what happens to the pressure in the lungs? Right? It's a pulmonary oxygen. Oxygen is a pulmonary vasodilator. It like decreases pressure in the lungs. And so lack of oxygen does the exact opposite.
So it's a vicious cycle.
It is a terrible vicious cycle. Exactly. And so they end up getting lower oxygen levels, which takes off their lungs and makes their vessels constrict even more, which makes their oxygen levels even lower. And then yeah, it's totally a vicious cycle. That's really hard to break, but it's actually a really common thing to see. And so you have to figure out ways to break it, looking at these things to try to influence it. And so what's one of the first things that you could do to try to break the cycle?
Need a chest.
Need a chest position is one thing, yes. So need a chest position will increase the pressure over here, right? Which will help to push. So by increasing the pressure here, it will kind of help to push some of the blood back into the lungs where it needs to go. What else could you do? Oxygen, yeah, oxygen, because that will help to decrease the pressure here, right? That will decrease the pressure here, which will also help to push blood back towards the lungs, right? And what else can you do? The kid's screaming, the kid's really fussy. Calm them down, yeah, exactly. Give them to mom, have them on mom's chest, because most kids find their parents to be a soothing place, yeah, a soothing, safe place. And so as they calm down again, that is going to decrease the pressure here some more, which will make it more likely for the cells to go to the lungs, which are gonna, it creates the cycle of the vicious cycle in the opposite direction, right? To being a good cycle. But then lastly, if those things don't work, then you can use some other pharmacologic things like beta blockers or phenylephrine or other vasoconstrictors or things that can actually like pharmacologically squeeze things over here and push blood back into the lungs. But the same principle applies like if they have a surgical shunt somewhere else. They have something that allows blood to go abnormally from the right side of the heart to the left side of the heart. And you want to maintain the balance to what it needs to be for that kid to maintain life. And these are some simple things that you can do to either help blood flow more to the lungs or blood flow more to the heart, or more to the systemic circulation. So, does that make sense? Like, and literally there's like thousands of these things, but that's kind of the gist of all of them, is that there's something that, some abnormal connection from the right side to the left side. Sometimes there's two abnormal connections, but these things can help to influence what's going on. And a little bit is good and too much can be bad, right? So does that make sense? I think that's just about everything for congenital cardiac stuff.
Well, what about CPR and little tiny kids? Is there anything you have to say as a doctor that would supplement what we already learned?
No. Basic PALS is the kind of the CPR Bible for kids. So what you learn in those courses is the gold standard. And that applies to kids that have abnormal hearts. That applies, and the H's and T's applies to them just the same. And really, in those situations, it's kind of the simple stuff. And I mean, sometimes there are some more advanced things that can be done, but those aren't things that you're going to be able to do on a rig. And oftentimes, honestly, they're not things that we'll be able to do very readily in the emergency department either. They're things that we'll have to do, like getting them to the OR and putting them on ECMO, where we actually put them on cardiopulmonary bypass. And when these things don't work, they end up going to the OR so that they end up having some kind of emergent surgery, which usually includes getting put on bypass, or they'll die.
Do little kids get ventricular fibrillation?
That's very rare. It can happen. I think I've seen it maybe twice. It's very rare.
So it would be unusual for them to have a shockable rhythm.
Correct. The vast majority are going to have PEA or asystole, and the vast majority of cardiac arrests in children are going to be pulmonary in nature. So it's going to be they drowned and they arrested, or it's a SIDS baby that arrested, or trauma that hemorrhages and then they arrest.
And the SIDS is because they can't breathe, because they're lying with their face in the pillow or something?
There are a lot of causes of that, and there's a lot of debate as to the exact cause of SIDS. That is one of the proposed causes of it, and the Back to Sleep campaign, putting babies to sleep on their back, has decreased the rates of SIDS deaths, but it hasn't taken it all the way away. And so there's other things that are associated with it. Some of those kids may have like undiagnosed metabolic abnormalities, where their sugars crash overnight, or any number of other things.
For a kid who has type 1 diabetes, will that onset immediately when they're newborn, or it takes a while?
It usually takes a while.
Like when would they start?
I've seen them like as young as 1 to 2 years of age, but for the most part, they tend to be like school-age kids.
Oh, I see.
So, and they show up breathing really fast and really they just don't look right there. Cosmal breathing, essentially. And again, if you have a kid that looks abnormal and looks like they're sick and you don't have a good reason, check a sugar. And sometimes it's low, but sometimes it's high. And if it's high, then you have your problem, right?
There's not much you can do, just transport.
Give them fluids. Put a line in and give them fluids and transport them, yeah. And they'll need insulin, and they'll need some pretty close care over the next few days, because especially the new onset diabetics, they can be really sick, and they can actually get sicker with correcting them. By fixing them, you can cause brain edema and things like that. So there's actually it's a challenge sometimes to fix them without hurting them. So anyway, any other questions? No? Does this make sense? If you ever have any questions about anything, don't hesitate to ask. And actually, I have like a little handout with this stuff that I was thumbing through and trying to get for you. I can send it to you right now. So
I
if you
can print
want.
copies out and hand them out to you then.
Okay. There's just one typo on it, and that is that for maintenance fluid for babies, I said to use D10 quarter normal saline, and it's D5 half normal, or D10 half normal is preferred. So, but then you can have something.
Yeah, we don't have it anyways.
But then you'll have something that it has all of this stuff written